The MCAS story started probably about 18 months ago, 2 years ago, in a very small way. But what has happened is that over the past 12 months with COVID, what seems to have happened, a lot of people with undiagnosed or misdiagnosed MCAS have come out of the woodwork. It seems to have unmasked the condition in a very big way, which is actually a good thing for COVID, because the medical profession knows diddly squat about MCAS. And trying to educate my colleagues is like pushing water up a hill, which is not an easy thing to do, but we're getting there. And I tell you what, the thing that's the most important is when I'm asked to see a patient who has multi-system problems, multi-system symptoms, has been around the houses, seen neurologists, seen cardiologists, gastroenterologists, rheumatologists, you know, you go on forever.
Immunologist, I mean, every doctor you can imagine.
And then you come and see a syncopologist. That's what I call myself. It's a neologism, a syncopologist. And you go through the story, and it is just mind-boggling. And what I find is that once you treat these people with H1, H2 antagonists and they get better, their doctor, their ears prick up and they say, what is this all about? And then they're very keen to know about it. So I think my approach is to treat the patient, see how the patient responds, and then watch the doctor's reaction. Very interesting.
And is there any way do these patients need to stay on these H1 and H2 drugs for the rest of their life, or is there another option?
It's very hard to say. Everybody's different. My experience is at the moment, most of my MCAS people are still on their H1 and H2. In some, we've tried to backpedal a little bit, but what happens is then they start to get the symptoms again, which indicates they need the medication. So we upscale it again. And that seems to be the experience that I'm having. And I think a lot of other people are too. I mean, in the ideal world, I tell my patients, I want you to be on the least medications possible. Because otherwise you turn them into a junkie. And you really don't want that. So it's the minimum medication to control the condition. So my aim is initially to control the condition, and then once they've been stable for some weeks, months, then start to backpedal with the medications and see what happens.
And there's a comorbidity with MCAS and POTS, isn't there?
That's very interesting, because what I'm finding is when I look back at my POTS people, I'm finding a lot of them have actually underlying MCAS. And when you treat the MCAS, lo and behold, you can cut back on their POTS medication. And I had an email yesterday from one of my patients who we started to treat for MCAS probably November, December last year. And he'd been treated for POTS for probably about 12 months before. And, it is reasonably well controlled. Now that he's on his MCAS medication, email last night, he says, Doc, can I cut back my evaporatine? Because my heart rate's so slow now. At Christmas it's going to 110, 120. When I stand up now, at most, it's 75. And this is what I find. You treat the MCAS, the POTSy things all come into line like little ducks walking in line. And it's very satisfying, not only for the patient, but for the doctor as well.
And is there anything else that you're using to treat the MCAS patients other than the H1, H2 blockers?
Oh, good heavens, yes. My heavens, that's only the start. I go through the role of histamine. I go through all the other things that one can use. So avoidance of triggers, I think, is one of the most important things. Making sure that they're not exposing themselves to something which is sending these mast cells into a flat spin. Then look at the histamine story, then the H1, then the H2. And quite often what I do is when they're established on the H1, H2, swap them over to another one, because some people seem to respond better to one H1 antagonist than another. Don't know why, and the same with the H2s as well.
That's very true. Yeah.
Also recommend that they think about things like quercetin, which is very useful. A lot of people find that that is a useful medication which they can buy over the counter, which seems to bring a lot of benefit. So we use vitamin C, 1,000 milligrams, vitamin D, 1,000 micrograms, the quercetin, probiotics. There's so much stuff that you can do. Montelukast, it all depends on the patient. So I try to tailor my management of the patient to their symptoms.
And all the things that you've spoken about are available over the counter. Do you ever feel the need to go to prescribe mast cell stabilizers?
Sodium chrome would like it. The problem with sodium chrome would like it is it's not very well absorbed. And a lot of people don't do awfully well on it. So I don't use an awful lot of that. I do use the eye drops and the inhaler. We used to have a nasal spray in the UK. It's been withdrawn, sadly. So we can't use that. If you live in the States, you can use a sodium chrome would like it nasal spray, but not in the UK. Montelukast I tend to use instead of. And some people can take it. Some people it doesn't suit. And again, it's like any medication. The problem with MCAS is there's such an individual response. There's such a wide range of symptoms that trying to get the correct cocktail of medications can take quite a long time. I think the message is don't give up. Keep trying, keep changing, and try to tell the patient, oh, that didn't work. Okay, that's fine. There's loads of other things we can do. And you keep plugging on, tweaking and readjusting until you get an optimum response.
Are there any lifestyle changes that you recommend to people with MCAS?
I said earlier, the avoidance of triggers, that's the major thing. And people can often recognize triggers. And the avoidance of that there, I think, is a very important first line thing to do with MCAS. And it's some people, in most people, if they can identify a trigger and avoid it, it helps. Some people find it difficult to identify triggers, and that's then more of a problem. But that's the first line of attack for sure, yes.
And then earlier, when you were saying that doctors are now getting more familiar with MCAS because of COVID, is that because of the long COVID patients?
Yes. Yeah, a lot of my patients now have had COVID, long COVID. And as I said, what seems to be happening is that the COVID is unmasking the MCAS. They've had the MCAS forever. And then whenever you start asking the questions, going through the systematic review, and say, oh yeah, I've had that since I was, knee-high to a grasshopper. I've had this, and I thought that was just normal. And then some people actually are quite amazed when they fill in my questionnaire. I got a 183-point systematic review questionnaire I give them. I ask them to highlight the symptoms that they have. It relates to all the systems in the body. They send it back to me. And the amount of highlighting can be quite astonishing. And they'll quite often say, how did he know to ask them that next question? Oh gosh, never thought about that. Interesting. Yep, fascinating.
Yeah, that's so true. I went through the same experience with my doctor. I mean, I never thought hypermobility, for example, would be something that, is related to all the symptoms that I've been having.
Yeah, absolutely. And as I say, it's all part of a spectrum. And it's the interrelationship of these conditions, the hypermobility, the POTS, the MCAS, all these things are quite often interrelated. And that's fascinating. It's actually, it's very satisfying as a medical practitioner to actually treat people who have been suffering, for years and years and years. And then you do something really quite simple. You're not using toxic medications. You're not using things that are going to put them at risk. And they say, wow, doesn't happen with everybody, but happens with a lot of people. It's very satisfying. It makes life worthwhile for a doctor.